Good morning. Okay, today we're going to cover axis deviation, bundle branch blocks, hemiblocks, and chamber enlargement. We've got a lot to cover. This is a fairly complex topic. It's a little bit more involved than what we've had in the past with just identifying rhythms. These are some hard concepts. And so you'll see on several of these slides, if you look at them, the notes section, I actually have writing on them. I hope to publish an article on this because it is such an important concept that nurses don't know. And so everything you see written down below is stuff I've written for this article. Anyways, we are going to cover the usual physiology, and we're going to talk today about electrical axis. And this is so important for understanding things like bundle branch blocks and hemiblocks. We're going to look at the different kinds of axis deviations, of course, bundle branches and hemiblocks, and the pathophysiology for atrial enlargement and ventricular hypertrophy. So let's just jump in. Okay, so let's see. When we look at the anatomy and physiology, I think you guys already know most of this, so let's just review some basic concepts. So the EKG reflects the time it takes for depolarization of different areas of the heart, right? So the P wave represents depolarization of, and you would say, if you were here in real life, the atria, and the QRS represents depolarization of the ventricles. Okay, so normally QRS depolarization takes less than what? We talk about this all the time when we measure our QRS, and we want it to be less than 0.11 or less. So I guess you could say less than 0.12. And then we know that if that QRS is wider than that, that there is some kind of delay in that ventricular depolarization. The reasons for this QRS prolongation, we've already established some. We look at this every day, and we have determined that some rhythms have a wide QRS because they originate where? They originate in the ventricles. So that's number one, that the reason for the QRS prolongation is because the rhythm itself originated in the ventricles, such as ventricular tachycardia or idioventricular escape rhythms. The second reason that QRS can be prolonged is because there is a bundle branch block. And a bundle branch block, basically what that means is that it's like a detour. Think about driving someplace, and now you've hit traffic and you have to take a detour around it. It's going to take you longer to get where you were going. And so that's basically the simplest explanation I can give for what a bundle branch block is. Okay, we know so far we've been heading in the systematic approach of interpreting rhythms. And on your quiz this week, I have given you a 12-lead EKG, and I want you to be able to follow all of this. Okay, you should be at this point after today's lecture able to determine the rate, the rhythm, the intervals, whether they be PR intervals, PRI, QRS. We haven't done a lot with QT. I'll probably cover that in a couple of weeks. But axis we're going to cover today. Hypertrophy we're going to cover today. And next week you're going to hear from Dr. Dina Bass, and she's going to talk to you about ischemia and infarction. So look how far you've come. You are now almost, by next week, the week after, we're done with school, and you will be able to do all of this. So when we look at a 12-lead EKG, the first thing is to give our descriptive analysis and then formation of a clinical impression. And we do all of this by describing these things, which we've been building on every single day. So just as a reminder, QRS complexes, because we're really talking about something that has interfered with that depolarization of the ventricles, that QRS complex can look very different depending upon what is going on and what lead you're monitoring in. And so I've drawn for you here, as best I can on a computer, different kinds of QRS complexes, and I've labeled them appropriately with the nomenclature. So remember that a large A large deflection is represented by a capital letter, and a small deflection of like less than 3 millimeters is represented by a non-capitalized letter or a small letter. And so you can see here, if we call these out correctly, this would be a QR. The very first one is a Q because there's a first initial dip, goes below baseline, and then a secondary deflection above baseline, which is the R. The next one is a QS. We can't tell whether that's a Q or whether it's an S. Remember, a Q goes below baseline and an S goes below baseline. And because there's only one, we can't tell what it is, so we just call it a QS. The third, QRS. And so is the fourth, QRS, but notice how there's a bigger dip in one, a bigger Q, and that's why it is capitalized. So recognizing this, we now come down to the bottom row here, and we can see RS, another RS, and now we come to a new concept, RSR prime. So we know that there is only, there's only one letter for what goes above the baseline, and because there are two of them, we call the second one a prime. And so you can see again the same rules apply about the size of it, and even when we get to this next to the last one, we say it's an RSR prime. That S doesn't actually fall below the baseline, but we typically call it that because it is a negative deflection. So it's positive, then negative, then positive. And we would say that's an RSR prime. And finally, the last one, an RSR prime, and you can see that bigger R at the end. Now, these are important because some of our bundle branch blocks create this very pattern. And if we go back to my analogy of driving and say there's construction on the road and you have to take a detour, that's what we're seeing here. We're seeing the electrical activity have to take a detour around an area of inactivity, basically. So remember about electricity. The electricity in our bodies, generated from our hearts, think about where that is coming from. It's coming from the SA node, right? In the normal person, with a normal heart. Well, even if there's abnormal, but let's just go with this for the moment. So the normal axis is supposed to be from the SA node down through to the AV node, then down the bundles and depolarizing the ventricles. Almost in the flow, if you could see me, from my right shoulder to my left hip. Remember, we've talked about this before. I think on the very first class and a couple since then, I've talked about the normal flow of electricity goes from the right shoulder to the left hip. And that is our normal axis. And in fact, we can see it right here, the normal flow of energy through the heart from the right shoulder to the left hip. And if we put the heart right here in the center of this circle, and we're looking at the patient here, okay? So think of it, or lay yourself in this picture if you need to. This is the right shoulder, this is the left hip. So everybody understands that we're looking at the patient's view here. And so energy normally flows in this direction. Now, the left ventricle is so much larger that we see that deflection of, we see that electricity heading towards. All right. We know, like I said, the normal is for energy to flow from the right shoulder to the left hip. And that would put us in this normal axis. So we're going where the energy travels to, and it goes to this normal axis. Now, we could also label this according to like a compass, right? So just to make it easier as I'm describing this to you, this would be northwest, this would be northeast, this would be southeast, and this would be southwest. Okay, so that's what the NW means right here, is northwest. So it's just a matter of trying to get some commonality in our, so that we're looking at the same stuff. Okay, so this is this southeast corner is our normal axis. And remember that a circle forms 360 degrees. So there's 90 degrees in each one of these, I guess, regions, if you would call them that. If we had a right axis deviation, meaning that instead of heading towards this normal, that the electricity tended to come straight down, that would be a right axis deviation. So the energy is now heading to the, I guess, southwest, if you would. Or you could have a left axis deviation, where this is very common. The heart gets bigger, right? In older people, the heart gets bigger. A lot of people have heart failure. And so it tends to shift left. And so the energy is now traveling more leftwards than it is towards this 90 degrees of the normal axis. Okay. So when we look at our 12 lead EKG, we can see a couple of things right off the bat. So number one, I don't know how much we've talked about this or how much you've retained, because I know I've mentioned it, but going back over, remember that EKG complexes, specifically the QRS complex, can look either positive or negative in deflection. And so when you're looking at this EKG, what you're seeing is that lead 1, 2, and 3. Notice that those are all positive. That is because energy is flowing towards those leads. And that makes sense. If we think about this, lead 1 looks from the right shoulder to the left shoulder, and that electrode is posted on that left shoulder or left arm, somewhere in there, and it's seeing that energy come towards it. So it's seeing it come towards it. It is a positive deflection. Conversely, look at AVR. Notice how that QRS complex is negative, and that's because that energy is going, we don't see energy coming towards that lead. Remember, AVR is a lead that's over here. It's on the right shoulder. And so energy should never be coming towards that right shoulder. That right shoulder, normal energy flows from the right shoulder to the left shoulder, not up towards the right shoulder. So AVR will always be negative. Now, when we look at axis deviation, we are looking to see, does energy travel in the pathway that is normal, or is it altered? And so it can be either a left axis deviation or a right axis deviation or an extreme right axis deviation. So what we do is we look at a couple of leads to determine this. So let's go to the next slide. So here you can see that exactly what I was talking about, how the lead 1 looks across the top of that inverted triangle, Einthoven's triangle, and it is looking at the energy. Lead 1 looks at the energy coming towards it from the right shoulder to the left shoulder. So it's looking at the energy being received by that left lateral side. Remember, you probably covered this with Dr. Bass last week, right? About looking at the leads that look at the different areas of the heart. And so lead 1 and AVL in particular look at the energy coming towards that left lateral side. Similarly, lead 2, 3, and AVF all look at the energy coming towards the bottom of the heart. Or what do we call that area of the heart? We call it the inferior portion of the heart. So when we are looking at axis, we are looking to see, does that energy follow the normal pathway? And is it a normal axis deviation? So we primarily look at two leads when we're trying to determine if what axis is on a person. So we look at lead 1 because that's always giving us our orientation from right to left. And then we look at lead 3 as I've got pictured here, or we could look at lead 2, we could look at lead AVF. Actually, we're going to just stick with lead 3 for right now. So I need you to memorize that you're always going to look at lead 1 and lead AV3 and determine if they are upright or if they are negative in nature. So is the electricity flowing towards them, meaning that it is positive? And you can see here in the southeast corner of this quadrant that we have lead 1 is positive, lead 3 is positive. So that is the norm with which we start. We always start with that. Then from there, you can see if you go right from there, if you're standing in the middle of this circle and you look to your right, then from lead, if you're facing normal axis and you go right, then you're looking at a right axis deviation in that southwest corner. So that right axis deviation, we're going to see that by noting that we're going to still have a positive complex in lead 3, meaning it's still heading towards the bottom of the heart. But it's not heading left. It's more heading just straight down. And so lead 1 looks to be negative because remember, think about where lead 1 is. It's up here on the left arm, up high on the left arm or even the left shoulder. And so that energy is not traveling towards it. It's pretty much traveling away from that lead. And so what we will see is a negative complex in lead 1. And because the energy is still traveling towards lead 3, towards the bottom of the heart, it is positive. Okay? So you have a normal axis deviation and a right axis deviation. And what you'll notice is that lead 3 in both of those is positive because still that energy is heading towards the bottom of the heart. The difference between them is it heading more leftward like it's supposed to towards that left hip, or is it heading straight down? If it's heading straight down, we're going to see a negative complex in lead 1, and we know that is because it's flowing away from the lead 1 up here. So that's why it's negative. Okay, so take a breath. The next one we're going to cover is a left axis deviation. And so you can see with a left axis deviation, it's heading left. That energy is heading left. The problem is it's not heading down towards the hip. It's just heading straight across the body. And so what we see here is we see that positive component in lead 1 because the energy is heading right towards it. But it's negative in lead 3 because lead 3 is standing at the bottom of the heart and it's going, hey, you're not coming towards me. It's negative. It's heading away from it. And so that's considered a left axis deviation. Now, the final quadrant that we haven't talked about is that northwest quadrant, and that would be an extreme right axis deviation. What this would mean is that all of the energy has to be heading up towards the right shoulder, kind of like over your right shoulder. And is that even possible? So I have never seen in person a live person with an extreme right axis deviation. This primarily happens just congenitally having the heart, malformed at birth. And I don't deal with babies, so I don't see those. But that's about the only time you would see an extreme right axis deviation where lead 1 and lead 3 were both negative. Okay, so we have now covered a normal axis deviation, and so let's just briefly review. Lead 1, and I'm going to go through each of these in the same order. So lead 1 in a normal axis deviation is going to be positive, and lead 3 is going to be positive. We have a right axis deviation where lead 1 will be negative, and lead 3 will be positive. Okay, and then we have a left axis deviation where we primarily are looking to see lead 1 will be positive, that energy is coming towards it, but lead 3 will be negative. And then, of course, what we never are going to see probably in life, the extreme right axis deviation, also known as no man's land. It'll be both lead 1 and lead 3 would both be negative. Now, what this slide is showing you is that we could have a pathologic and a non-pathologic cause for a left axis deviation. So if we think about this, I've said a couple of times now that as people age, their hearts get bigger, their PMI shifts to the left. So there is a component of that that we consider normal. And we say that is a non-pathologic left axis deviation, meaning it's just a little bit. They have just a little bit of left lateral shift, and that happens with aging. And so we say that's okay. As we get older, our bodies change, unfortunately. We develop wrinkles, we get gray hair, and our hearts shift a little left. And so it can shift a little amount. So a small degree, it can shift less than 30 degrees is what we typically say. And we call that a non-pathologic left axis deviation. Now, when it becomes of concern is when it's greater than that 30 degrees. And we say that's a pathological left axis deviation, meaning it is associated with heart disease. And so we look at one more lead to determine this. So remember that our two key leads that we've already been looking at for axis are leads 1 and 3. Now we're going to throw in the middle one. We're going to throw in 2. And so when you look at lead 2, what you're going to look at, and you're only going to do this if lead 1 is positive and 3 is negative, that tells you you have a left axis deviation. Now we look at lead 2 to determine is it pathologic or not. And what we see is that we call it pathologic if in lead 2 it is a negative complex. So you only do this, you only check lead 2 when you already have a left axis deviation. I'm not going to check lead 2 if I have a right axis deviation or if I have normal. I'm only going to check it if I have a left axis deviation, so meaning that lead 1 is positive, lead 3 is negative. Now I'm going to check lead 2, and if it is negative, then I say it's pathologic. But if it is positive, I say that this is a non-pathologic left axis deviation. So let's take a look at the EKG. So this one's kind of fun looking. There's already a problem with it I can see right off the bat, and that is that those QRS complexes are fairly wide. So that's going to be important, and we're going to talk about that next when we talk about bundle branch blocks. But let's just look at it for axis and try to figure out what we've got going on here. So what are our two key leads that we're going to look at first? We're trying to determine straight up what the axis is. We're going to look at 1 and 8 and lead 3. And so 1 is positive. And what you may want to do is just draw out a hashtag, not a hashtag, a cross, right? Plus sign. And you know your different quadrants. So you now have 4 quadrants. And you know that if lead 1 is positive, that it's going to be somewhere on that right side of that plus sign. So it's going to be in that right-hand column. And now I'm going to look at lead 3. And if lead 3 is positive, it would be towards the bottom because that's the way energy is supposed to flow. But in this case, it is negative. So it means that it's in the upper portion. So I know I'm in the left upper, I'm trying to think of the words to describe this to you. I'm in that northeast corner. And so that tells me it is a left axis deviation. So it's a left axis deviation. And what is the lead that I need to look at to determine if it is pathologic or not? I need to look at lead 2. And when I look at lead 2, I see that it is negative. So it is pathologic left axis deviation. Okay, so now we're going to jump into bundle branch block and what that has to and how we identify it and what it actually means. So here's the good news. When we think about bundle branch blocks and what we're looking at, there are only 3 choices. It's really easy. So if we break everything down into components, when we thought about axis, there were only 4 choices. So even though we might have You know, how many rhythms are there that we learned? 23, maybe 24, somewhere in that. Now, when we start looking at these advanced components, the good news is that we have several things that we're going to look for, whether it be axis or bundle branch block or hypertrophy or etc. But there were only 4 axes, and there are now only 3 bundle branch blocks. So we only suspect a bundle branch block when we have QRS widening. So I oftentimes, every single semester, have students that are looking for a bundle branch block, but the QRS isn't wide. Don't worry about it. If the QRS is not wide, you don't have a bundle branch block. So that means it's the very first thing on this slide. So we are looking, is the QRS wide? And how wide does it have to be? It has to be greater than 0.11. So if you remember early on, we started looking, we called everything normal if it was 0.12 or less. There's actually a little hair of a difference, and it's 0.11. It's greater than 0.11. So some things that are 0.12 can be bundle branch blocks, but usually they're going to be, 0.14, 0.16. Very rarely is it just exactly right on 0.11. So in general, we think 0.12 and greater is a bundle branch block. Now, what kind of bundle branch block is it? So it is either a typical right bundle branch block, or it's a typical left bundle branch block, or it's neither one of those. And we say, well, then we call it an IVCD. So when it doesn't meet the criteria that I'm going to teach you here in a minute for typical right bundle branch block or typical left bundle branch block, then we call it an IVCD, an intraventricular conduction delay. Okay, so please note the bottom box here, and this goes back to how this whole lecture started with saying that there are 2 reasons that you could have a QRS complex being wide. One, that it is originating within the ventricles. So you have a ventricular tachycardia, that looks pretty wide, right? Or it's a bundle branch block. There's some kind of defect in the conduction or delay in the conduction. All right, so let's review. So looking at this slide, what we see here is we see the SA node, the AV node, and then the bundles coming down from the AV node. And so we have all those little interconductional pathways, channels that go from the SA node to the AV node. And what that does is it depolarizes the atria, of course. And then that impulse that originated in the SA node, so it originates there, it conducts down, it depolarizes the atria, it lands, I guess you would say, in the AV node. And that AV node, remember, it holds onto it for just a fraction of time so that that atria now has time to contract. And then the AV node releases that impulse, and it's supposed to flow down the bundle branches. So there are both a left and a right bundle branch block. Bundles. There's both a left and right bundle. Now, what is supposed to happen is that they are both depolarized at the same time, and therefore that means that they have contraction at the same time. That provides the most optimal cardiac output. When you have something that's working synergistically together, so you have contraction of the ventricles at the same time, then you have the best optimal contractility. If you had one contracting and then the other, then this puts it where this septum is actually kind of swinging back and forth, and when one contracts, it actually impinges on the other, and so you don't have good cardiac output. So when we have somebody that has a bundle branch block, one of the things that we need to consider is that they are not going to have optimal cardiac output. So having a bundle branch block basically means that you have run into a detour. So we're going to work through this in the next couple slides. One thing I do want to point out to you here is that, again, because the left ventricle is so big, so much bigger than the right, it has a little extra help. It has both an anterior branch of the left bundle branch, and it has a posterior branch. So it breaks into 2 so that it can fully depolarize the whole left ventricle at one time through 2 different branches. So you see here that you can have a blockage on the right bundle branch block, or you could have a blockage high up on the left bundle branch block, and this would create a full right bundle branch block or a left bundle branch block. Now, when you have a bundle branch block, basically what that means is it's just like there's been a giant accident or there's been some kind of defect and you can't get around it. So think about driving your car. You come up to an area that has work, has an accident, has whatever, and you have to turn around and go a different way. It's going to take you longer. That's basically what we are seeing on the EKG. That impulse started to come down those bundles, but it hit that roadblock and it had to basically turn around and go back. We don't often have somebody that has blockages in both the left and the right. If we did, we would say that was third degree heart block because they are not getting anything conducted. The atria is not is going independently, but every time it tries to send an impulse down those bundles, it's not working. So that would be third degree heart block, and that's where the Purkinje fibers would have to fire. And that's why one reason that you would see a third degree heart block is if you had both bundles were now blocked. So I've only drawn this picture though for representation as to where this could occur. Now, how do we identify this? One thing I want to do is, just like we started off the beginning of this lecture talking about the deflection and if it can be positive and negative and how they can look differently, we also need to make sure that we're using the same nomenclature or same descriptors in talking about our QRS complexes. Because even though this is just an RS, we call it a QRS, right? But when we start looking at defining, is it a left bundle branch or a right bundle branch, we have to be really clear on our speech here. And so we definitely want to call that top one on the right, that is a QR. Notice that the Q is a small q and the R is a big R, capital R. So the small letters indicate that it is less than 3 millimeters, and capital letters mean that it is greater than that. We have typically the very first complex that you see there on this slide is a QRS. And notice that the one next to it to the bottom is an RSR prime. That little hash mark means prime. And so we know that because R's are positive deflections. So we always label these the same way. A Q is the first negative deflection. An R is the next positive deflection. An S is the second negative deflection, or a negative deflection that follows a positive deflection. So we could actually go out from here. It's rare, but we could have an RSR prime S prime. We could have a more of an M shape look to this, or even an M into a W. So it's all good that we're talking on the same page as far as using the same nomenclature and being able to identify an RS, a QS, a QR, etc., and then what the primes stand for. The prime means that it follows, if we've used the letter once and we need to use it again, we use the prime sign. Okay, so when we look to see what if there is a bundle branch block, we look at three key leads, and you'll need to write this down on this slide because I don't see it there. We look at V1, V6, and lead 1. So we'll talk about lead 1 in a minute, but I want to talk to you about why we are looking at leads V1 and V6. So what you see on this slide is at the top is the normal, in the middle is a right bundle branch block, and on the left, on the bottom, is a left bundle branch block. And so the reason that we can see these alterations in here is that these leads look, these EKGs look very different, don't they? We're looking at a single complex here. And if you look at the top, normal for V1 should be primarily negative. So you have a little bit of an RS complex. So you have a little R and then an S. And that's completely normal in V1. And whereas in V6, we have maybe a little Q and an R wave. And so if you look back at the slides at the EKG, And I'm not sure I can do that with a recorded PowerPoint. I would, in class, I would go back to one of the 12 lead EKGs that we have looked at. What we see is that V1 in a normal EKG always starts off being negative. And then if you remember, V1, V2, V3, V4, V5, V6, you can actually see a transition of that EKG complex going from being primarily negative to being positive. And so what you'll see is that in lead V1 it's negative, in V2 it may be negative, but it's starting to get a little positive. There's a positive component to it. By lead V3 or V4, that EKG complex, that QRS should be standing upright. It should be completely positive. And it's the same with V5 and V6. It should be positive. And so that's what you're seeing here. The normal is that V1 is negative, and it has that RS component to it. And V6 is primarily positive with maybe a little Q, but a big R wave, okay? Now, compare that or contrast it to right bundle branch blocks and left bundle branch blocks. And we see these things look very different. So number one, they are wide and bizarre. Remember, it has to be 0.12 or greater. So they're wide QRS complexes. And you notice that the right bundle branch block in V1 has almost an M shape to it, or some people call those rabbit ears. So it's an RS R prime, with that second R prime being a large R. And V6 looks kind of like the other one. It looks kind of like the normal, maybe has a little bit of an S component to the end of it. Left bundle branch blocks in V1 have, they're very deep and very wide. And so they just have an RS, QS is what we call that. QS because we're not sure if it's a Q or if it's an S. But so it's called a QS because it's the negative component. It's just a single large wide V look to it. And in V6, when it finally comes around, it's wide, it's bizarre, it's got this little notch to it. So it's an R with a notched, another R into it, perhaps you would say. So it looks very different. Now, what's the trick to remembering these? I will tell you my trick, which is I always look at V1. And if it is wide and bizarre and it is primarily upright, then it's a right bundle branch block. See how that is upright? The right bundle branch is primarily upright. It's got a positive component to it. So I say that that is a right bundle branch block. Well, I actually carry around a little cheat sheet. It's in your modules. You can print it off, put it on your clipboard, and you can do that for this class as well. You do not have to have these completely memorized at this point. It took me years to memorize what these looked like. And so I understand that, and so you're completely allowed to use cheat sheets on this, and I've given you some. Notice that the left, and so the right is upright in V1 and the left is not. That's just how I look at it. The left is negative. And then I look at V6 and I see that V6 still looks kind of normal in the right side, and in the left it doesn't. It looks very different. But this makes sense, doesn't it? Because we're talking about a right bundle branch block or a left bundle branch block. So if it has to turn around, if it starts going, if it's a right bundle branch block, and the impulse is going down that right side, heading towards, remember that V1 is looking at the right side primarily. And so if it's looking at it, but then it has to turn around and take a detour, that's what that kind of looks like to me. V6 is looking at energy coming towards the left side, and so there's a little bit of a late component to it. That's that S wave, but otherwise it looks like a normal complex. As comparatively, the left bundle branch block, that is very wide and bizarre looking in V1. Again, the V1s, think of where that sits on the right of the sternal border. And so it is reflecting that it's having an impulse that is not going down the left bundle branch block. And then V6 definitely looks like it started to go and then it turned around and went a different direction. Is kind of how I think of him in my head. All right, so when we come to this EKG, when we look at an EKG, let's actually go back a second and say, what is this person's axis, first of all? So 1 and 3 are the two leads we're going to look at for axis, and we see that 1 is upright, so I know that it is somewhere on the right-hand side of that plus sign. And then 3 is kind of biphasic. So I would say it's mostly right around normal. It's probably a normal axis. Maybe it's sitting on the edge of the left axis deviation. So possibly it's a left axis deviation, but now the question is that pathologic or is that physiologic? And because lead 2 is positive, then it becomes a physiologic left axis deviation. And it's just barely 1 if there is one. Okay, so we have our axis. Now we're going to look for bundle branch blocks. And we look at V1 and V6. Well, number 1, I can tell that it's wide and bizarre. That QRS complex is a good 0.16 to almost a 0.2. Go to the widest one that you can see, and that looks to be about V2 to me, V3. And that's almost a full little box, big box. So I would say about 0.16, maybe close to 0.18. So it's wide and bizarre looking. V1 looks very different. There is an RSR prime component, so we have that classic rabbit ear, and it's also primarily upright. And then I look at V6 and I see it looks about like it should. It's got an S component. That's the only thing that's new about this. So I would say this is a right bundle branch block. Okay, so coming back to our picture here, and we just saw an EKG with a right bundle branch block. Now let's really focus in on the left bundle branch block. So the electricity is started down that left bundle, but it's run into an obstacle. And so what we see is a huge wide QRS that looks very different in both V1 and V6. So that energy has had to find an alternative path around. It is not heading anywhere close to that V1 lead, and so it's negative. It's heading away from that V1 lead, but it is finding an alternative path around towards the V6. It's trying to get that energy over around to that left side. Think about where your EKGs are placed. They're placed walking around the heart or walking around the left breast, and so it comes around to that far left lateral side, about V5, V6 on the, fifth or sixth intercostal space on the left sternal border. That's where you place that V6 lead. And so it's looking at that energy coming towards it and depolarizing. And so it's pretty wide and bizarre looking. And so we'll look at it on an EKG. Let's see. So this is pretty much a classic EKG looking at a left bundle branch block. I know it because I can see it in lead V1 and V6. And what I see here is that very deep QS component to lead V1, very wide, very bizarre looking. And then when I look over at V6, I see it is wide, and it is just very odd looking. So again, use those cheat sheets that I've given you. You will notice that in both the right and the left bundle branch blocks, V6 and 1 look very similar, whether it be for a left bundle or a right bundle. Notice how lead 1 and V6 look very similar here, and V1 is the outlier. So that's why I come back to my little shortcut of if I look at V1, if it is upright, I start thinking it's going to be a right bundle branch block. Then I'd look at V6 and 1 and make sure that number 1, they look very similar because they should be congruent, and try to explain it in my head. Okay, why is this delayed? Because that's all it is. It's a delay. It's a blockage. It's a delay in the conduction of electricity down those bundles and having to find a reroute. About them primarily being these big fascicle, the whole bundle branch being blocked. This was typical left, typical right bundle branch blocks. Okay? The thing that can happen is you could have just one of these littler fascicles being blocked in the left side. You could have an anterior branch be blocked, or you could just have the posterior branch blocked. If you had both blocked, what would that be? That'd be a full left bundle. If you had a little blockage here and a little blockage here, say they were both, one here and one here, that would be a full left bundle branch block. But you could just have the anterior blocked or just have the posterior blocked. And actually this anterior being blocked is fairly common. It's common because the only blood supply that feeds this anterior branch of the left bundle is the left anterior descending artery. And so if you've done any time in the cardiovascular world, that is a very common place to develop coronary artery disease. It is a very commonly bypassed artery, our left anterior descending. You're going to learn a whole bunch about that next week. So that anterior branch of the left bundle is commonly blocked. And so it's posing a minor delay in that electrical impulse moving through. It doesn't have to get depolarized all the way from the right side. It just gets it from the other side of the left. So it's a little bit of delay here. And so this anterior branch of the left bundle is very commonly involved, and that would be a hemiblock. We would say if one of these was blocked, that's a hemiblock. It's not a full bundle branch block. It is a hemiblock. So it's one small fascicle is blocked. Now, how can we tell this? I told you it's very common to have the anterior blocked. It's much more uncommon to have the posterior block, mostly because this has a dual blood supply. This is fed both by the circumflex and the anterior. So this has a dual blood. Now, remember when we talked about the pathologic left axis deviation? We checked 3 key leads for axis. We checked 1 and 3, and then we looked at lead 2 to help us determine. And remember that if lead 2 is negative, lead 3 being negative as well, I didn't even put that up here, but if lead 2 is negative and lead 1 is positive, that's a pathologic left axis deviation. You can write on your paper right now a pathologic left axis deviation of LAD, pathologic left axis deviation, equals left anterior fascicular block. It equals. So this alone, when you pick out a pathologic left axis deviation, it automatically, unequivocally means that you have a left anterior fascicular block. Okay? So that's an always. So you could, when you are interpreting an EKG, you might very well write down pathologic left, you're going to determine axis, so you're going to say if it's an axis deviation or not. You're going to say if it's pathologic, but in your interpretation then, so let's say it was sinus rhythm, and they had a pathologic left axis deviation, you would say sinus rhythm with a left anterior fascicular block. That would actually be part of your interpretation because you have that pathologic left axis deviation. It's a always and forever. One equals the other. So when you find that pathologic left axis deviation, it automatically means you have a left anterior fascicular block. Now, oh, I have it right here. So it's just always and forever. Whenever you have this left anterior fascicular. The left posterior fascicular block, so the back side, that smaller one that's harder to block because it's got a dual blood supply. It's also harder to recognize, and we can only suspect it basically. So we suspect it by looking at a couple of things. We suspect it when we see number one, a bundle branch block. Now, which kind of bundle branch block? Let's take a look here. What were our leads that we looked at? We looked at V1 and V6. And right off, I can see that V1 is primarily positive. So I'm thinking upright. And then V6 is kind of the way it's supposed to look. And then 1 looks a little weird, but this is weird because of this posterior fascicular block. So this is number 1. Let's do our full interpretation. So of course we would have looked at the P and the PR interval and counted out what kind of rhythm it is and what the rate is and all that stuff. But in just looking at the bundle branch block, we would say this is a right bundle branch block. So this person has a right bundle branch block. We suspect that they also have a left posterior fascicular block because of these big S waves right here. So notice how they have this big S wave in lead 1 and a little bit in lead V6. And so we tend to think that is a left posterior fascicular block, or we suspect it. That's all we can say, that they have a left posterior fascicular block whenever we see a deep S wave in lead 1. Often in V6 we'll see it as well, because these leads often look very much alike. And so we would say this person is sinus rhythm, looks like they have a first degree AV block. Wouldn't you say? That looks to be, let's see, it's close. Oh, that's not so bad. It's close. So it looks to be sinus rhythm. Let's see, 300, 150, 175. So at a rate of about 75, they have a bundle branch block. Oh, did they have an axis deviation? What are our leads that we look at there? 1 and 3. Well, that's kind of negative. That's positive. Oh, what was that? Remember that? So that would be a right axis deviation. That's another sign of a... Oh. Okay, sorry about that. I had a class, so I had to sign off from recording, and now I'm back. So I'm not quite sure. I know we were on this slide. Let's see. We were talking about left posterior fascicular blocks, and real quickly, I'm not sure how far I got with what the criteria were for this, but the criteria for suspecting it, a left posterior fascicular block, are a couple of things. I think I had just mentioned right axis deviation. So here you can see right axis deviation. Remember, we are looking. The next one is IVCD, intraventricular conduction defect or delay, whichever word you like best there. What we see with this is, with an IVCD, is that we just cannot, so we know that there is some kind of delay, we just can't, I call it a clear or right. And so what we look at is, remember that we typically start with looking at lead V1, and V1 has that upright look to it, so it's making me think of a right. bundle branch block. But remember, with a right bundle branch block, leads 1 and V6 should look fairly normal. They should look pretty much upright. And we are not seeing that with this example. And I'm showing you this. This is primarily what your homework or your quiz is going to be. This is about half of it. Gives you exactly this kind of snippet to look at and to identify. And so this one would be an IVCD because it is not clearly a right bundle branch block because 1 and V6 looks so different. And V1, it looks like a right. So if it can't be a right and it can't be a left, then we just call it an IVCD. That's really all there is to an IVCD. So it just means interventricular conduction defect. It is something. There is some kind of bundle, but we can't tell exactly what it is. Okay, so next, let's talk about the typical secondary ST segment and T wave changes that accompany bundle branch blocks. Okay, so when we look at a bundle branch block, it is this wide and bizarre QRS. It has a problem with depolarization. That's the whole issue, right? Is that there is a conduction defect that is prolonging depolarization. So what does that mean? It means it also alters repolarization. And so what we see is that the repolarization, the T wave and the ST segment are also altered. Now, sometimes when we look at a big EKG, when we look at an EKG 12 lead from somebody having with a bundle branch block, it can be a little bit shocking because you look at it and you think you're seeing ST segment and T wave elevation or flipping, signs of a myocardial infarction. But actually those are just the normal, what we call secondary ST-T wave changes. So what can we expect? Exactly what this slide shows, which is that the ST segment and the T wave are in the opposite direction of the last deflection of the QRS complex. So walking this through, if we look at this one that says typical right bundle branch block, our QRS is upright. So we have the RSR prime, and that because the last deflection is that R, it's above the baseline, then our T wave is going to be negative. It's going to be inverted. Whereas if we look at leads 1 and V6, what we see is the last deflection was the S wave, a negative deflection, so therefore the T wave is upright. And because these T waves are kind of big and marked, sometimes it looks like the ST segment it looks like it's elevated or depressed, and it's just a little odd looking, as you can see from these pictures. So this is normal. This is how we can, we look at this and we say, oh, that's just the bundle branch block that is causing those ST-T wave changes. And we accept them as being what is normal for somebody with a bundle branch block. So if you look at typical left bundle branch block, the last deflection was that QS, right? Or actually that's probably a little RS. That's a little R, so it's B and S. That S is being negative, being a downward deflection, so therefore the T wave is positive. And then also in leads 1 and V6, you can see just the opposite. It was an R wave, and so the T wave looks to be flipped or inverted. And that's all there is to it, to ST-T wave. So we made it. We made it through axis and bundle branches. Those are really the two hardest concepts, I think, in this whole entire course to get your head around. But I've tried to make it easy for you by giving you some very simple things. Now let's review just quickly. What are the 3 leads you're going to look at for bundle branch block? you're looking at V1, V6, and 1. And what are the two leads you start at looking for? Axis deviation. We start off by looking at 1 and 3, or it could even be 1 and AVF, doesn't really matter. And then if we have a left axis deviation, we look at lead 2 to determine if it is pathologic or not. Okay? And so if you can memorize the leads that you're supposed to look at, then the rest of this kind of falls into place. If you can draw out the grid for axis, you'll be doing well. And like I said, I've given you a cheat sheet. Okay, so now we are going to move on, and we're going to cover basically chamber enlargement. We don't typically call atrial enlargement hypertrophy. We do call ventricular enlargement hypertrophy, but atrial enlargement primarily because it's more that it's dilated out, not that it gets thicker in the atria too much. Okay, so what we see is that we can have dilation or enlargement, hypertrophy. They're usually a response to pressure or volume overload. And so when the heart is having to work extremely hard for a long period of time, it is a muscle and it will grow thicker. And so it initially starts off, as it says in the last line there, as a way of as a helpful mechanism, but it can become pathologic at a certain point. And so what we see is a normal heart on the left-hand side of your screen, and then a hypertrophied, enlarged heart on the right-hand side. And you can see that it even gets bigger in the septum. And so notice that as the muscle gets bigger, the chamber size is reduced. And so this has a lot of implications for how much volume is needed and for how much volume it can hold for the whole hemodynamic picture of a person. In general, people with, I guess, beginning stage hypertrophy have a good cardiac index, maybe even great. But as it progresses and it becomes more pathologic, it impairs this, and so they have a diminished cardiac index or cardiac output. All right, so we're going to talk about what this looks like on the EKG, because we know that the electrical cells now have to depolarize. They are being, they're kind of stretched themselves because this heart is now bigger and it's built up the muscle. It's not that it grew more electrical pacemaker cells, it's that they're kind of stretched out now. So we can see that there's a problem with this electrical circuitry. And we see that on the EKG, and we can tell how big this heart is. Well, we can get an estimation that it is enlarged because of some things we look for on the EKG. So, atrial enlargement, we can have, of course, right and left. These are often due to pressure and volume overload, and they can be mild, moderate, or severe. It just depends upon, how they're handling it. And you can have both atrial have enlargement. So when we see right atrial enlargement, you can see that this right atrium here, just very ugly, isn't it? Is bigger, and we see that a lot of the energy, a lot of the electricity is heading downwards, whereas opposed to left atrial enlargement, that now most of the energy, most of the electricity is moving towards that way. So energy tends to go where it's bigger. We can contrast these by just remembering a couple of things. Now, if we think about right atrial enlargement, that's on our pulmonary side, that's on the venous side, right? And so it's most often a problem because of something in the pulmonary system, whether that be PE or COPD or pulmonary hypertension, or it could be a congenital heart defect, but it's usually something that's on the right-hand side which has caused it to back up. So let's take the example of a pulmonary embolism. You now have a blockage within the pulmonary vascular system, and the blood is not flowing as easily through the lungs as it should. So what happens when blood isn't able to move forward as it's supposed to? It backs up. So it backs up to the right ventricle and then to the right atrium. And in fact, that's one of the things that you can see very early on in somebody with a PE is this right atrial dilation. So think of right atrial enlargement as being related to something typically with the pulmonary vascular system. Conversely, the left side of the heart, of course, pumps out to the body. So typically what we see there are more kind of systemic issues like uncontrolled hypertension, or valve issues on that side, mitral valve stenosis or regurgitation, or even aortic valve, and backing up again from the left ventricle into the left atrium. If it just typically progresses from one to the other. What you wouldn't see is if it was the mitral valve, we wouldn't have a problem with the left ventricle. We would only have a problem with the left atrium, right? So that's where you would have pure left atrial enlargement. Let's see here. So things that we're talking about here are so like that mitral valve right there. So you can see as issues happen, blood backs up and it causes enlargement of these different. So typically, you may not have any symptoms for early stage enlargement, left and right atrial enlargement, but you could have some things. High blood pressure, atrial fibrillation is particularly common in people with left atrial enlargement. Again, I think it's because of the stretching of the cells, and those pacemaker cells are there, and they're kind of irritable now. And of course, typical signs and symptoms of heart failure and cardiomegaly, depending upon how severe they are. With a left atrial enlargement, I like to think of this as being more related to the mitral valve. Remember that the mitral valve can be a problem. This is the left atrium, which feeds into the mitral valve. So I think about the mitral valve and I think about an M, and it's kind of an M-shaped or a camel hump P wave. And we're looking at a couple of leads for that. Typically, for left atrial enlargement, we'll see this in V1, in lead 2, and we'll see these M-shaped leads. You can actually see it in more than just those leads, but looking for a P wave that is kind of M or camel-shaped, or it could even be biphasic, meaning that it goes above and below the baseline. So kind of a funky sine wave, if you would, as compared to a typical P. We're seeing here, see this little hump here? This is V2, but we definitely have like a couple of components to this P wave. This is not your normal P wave. Looks kind of humped. And so so they're calling this one right atrial enlargement is this one. This one is what is it's a little bit suspicious. And then here we can see, oh, there's a classic one with this P mitrale. Here we can see the biphasic waveform that I was talking about. The P wave kind of goes above and below the baseline. That's in lead V1, and then we have this M-shaped P mitrale kind of a humpback, camelback um, P wave in lead 2. So that would be left atrial. Okay, so um, so when we see this, we obviously have to suspect that there may be either some structural issues going on that possibly can be fixed. Perhaps they need valve replacements, whether that be um, a valve repair or replacement. Interesting, this says right atrial enlargement has got mitral valve. I just noticed this on this slide. That should actually be what valve? Not mitral. It should be the tricuspid valve replacement. And then we should have mitral over here under left atrial enlargement. So you can see other things here, of course, medications. And what are these medications used for? Primarily for heart failure. Controlling blood pressure, it would be a good place to start with left atrial enlargement, and of course all of our modifiable risk factors. If it's because of atrial fibrillation, may consider ablation and treatment for that. And then, of course, ICDs, because we know that people with a reduced ejection fraction are more likely to have a lethal arrhythmia, sudden lethal death. So, if non-congenital, importance of exercise, losing weight, decreasing cholesterol, signs and symptoms of stroke and ischemia related to the atrial fib, heart failure, you're basically treating them like they are heart failure patients. With ventricular hypertrophy, we see changes. So it makes sense, right? You see atrial changes, you see changes with the P wave. With ventricular hypertrophy, we're going to see changes with the QRS, okay? And typically what we're looking for is that it's going to be bigger. So we have a QRS than normal. And so here you can see hypertrophic cardiomyopathy, this really thick wall, again, a different picture, and a small. We already talked about the cause is most likely due to overload, could be aortic stenosis. So, clinical presentation is typically related to heart failure. Okay, shortness of breath, they may have some chest pain, fatigue, may have palpitations. The thing with left ventricular hypertrophy is that it is really a variety of people have come up with ways to diagnose this from an EKG. More than 40 different criteria exist. We typically use words like we see changes that suggest hypertrophy, rather than making a full diagnosis based just upon an EKG. What we really need to get is an echo. That's really going to show us the structural enlargement that we are saying is here. And so it's not, the EKG is not an extremely accurate diagnostic tool. It is very indicative. And so it's a cheap tool, and so we often start there. But if we found something on there, we would obviously want to follow up with an echocardiogram to actually visualize it. So here are some simplified EKG criteria. This is what I typically look for. So I look at V1 and V5 and V6. This is for left ventricular hypertrophy. I take the deepest S wave, whether it be in V1 or V2, and I count up how deep it is. So let's say it's 4 big boxes. It's really deep. And then I add that to the tallest R wave in V5 or V6, so whichever one that is. And so if it's 20 in one and I get 20, if it's 20 in V1 and I have the same in V6, another 20, I add those together, 20 plus 20 equals 40. That meets a criteria of being greater than 35 millimeters. And that is one of the easiest ways to remember left ventricular hypertrophy is look at whatever is the biggest one in V1 and V2 and add it to the other one of V5 or V6. If the another thing to look for is the R in lead AVL. If you remember, AVL typically is a much smaller lead in general, but if it's big, if it's greater than 12 millimeters, so 2.5 boxes, 2.5 big boxes, then we typically think that that is suggestive of hypertrophy as well. Now, that criteria for being greater than 35 millimeters is good for people that are over 50, that are over the age of 35, okay? If they are younger than 35, then we have to go with a higher voltage of 53 millimeters. So, why is this? Because younger people tend to be more athletic and they have more muscle mass than older people. And so for them, it may be completely normal that their heart is bigger in relation to the rest of their body than somebody who's over the age of 35. And so we just flip the numbers. So for anybody who's young, even a child, and we get an EKG, we need to meet the criteria for hypertrophy. Their tallest or deepest S wave in lead V1 or V2 plus the tallest R wave in V5 or V6 has to be greater than 53. So just flop those numbers. And then finally, the last thing is we look for strain, meaning that the ST segment is being pulled by the QRS, kind of pulled down. It's got T-wave, ST depression or T-wave inversion, and that is indicative of strain. We'll look at a couple of EKGs here that show. Okay, so let's see here. Remember we started off and we said we're going to look at V1 and V2, and which one's bigger? Well, by far, V2 is bigger in this EKG. Would you agree? It goes all the way from here down to here. So we're looking at 5, 10, 15, 20, 25, 30, 35, 40, almost 45 just in V2. Plus now the tallest in V6 or V5, and wow, I think V5 is tall. We got 5, 10, 15, 20, 25. It's halfway buried up into this other. That's another 30 at least. So 30, and I lost count. Where were we? I think we're like at 70. So that most definitely meets our criteria. The other thing, remember, was to look at AVL. AVL typically is a small little lead. Here it's great big. 5, 10, it's almost 15 millimeters. So that meets our criteria right there. Okay? So, oh, and then the strain that we were talking about. See how that AVL, that QRS, and then the T wave is kind of pulling towards, the ST segment is sloping towards that T wave. Here we actually see almost some ST segment depression being pulled into this T wave. For the most part, these look to be, when we look at this EKG, I can clearly see that that QRS complex is wide. Is it greater than 0.111? Excuse me, 0.11. So it's greater than, it's at least 0.12. Let's see, 5, 1, 2, 3, 4. It's about 0.16. It's pretty wide. So there's definitely a bundle branch block. So if we were going to interpret all of this, of course, I would start off that there's a P, it's regular. There's a P for every QRS, P for every QRS. What's my PR interval? Looks to be at least 0.20, maybe 0.22, maybe a first degree. The rate of this rhythm is 300, 150, 175, a little bit less than that, so I would say probably 70. So a rate of about 70. Looks to be sinus. There is a bundle. What kind of bundle is it? Well, V1 is negative. V6 and 1 are upright. I am not seeing, I'm leaning towards, not seeing any notching of the R wave in V6. It's primarily, it might be an IVCD because it does not meet all of our firm criteria for a true left bundle branch block. There is, oh, do we have axis deviation? 1 and 3. So, yep. What kind of axis deviation do you think that is? Left axis deviation. And is it pathologic? I check lead 2, and it is negative, so it's pathologic left axis deviation. So now I know that a pathologic left axis deviation is automatically means they have what? They have a hemiblock. So they have a posterior hemiblock and some other kind of intraventricular conduction defect. And they have hypertrophy. So this is a big old heart, isn't it? It is a big old mess of a heart. And they have left ventricular hypertrophy. So that's how we basically kind of evaluate an EKG. We start off by doing our rate, our rhythm, our intervals. We look for axis. We do bundle branch evaluation, and then we look for hypertrophy. Now, so we have left ventricular hypertrophy. Do we have any atrial hypertrophy? My P waves look a little wide. They're not necessarily notched, but they do look a little bit wide to me. So it might go along that they have some left atrial enlargement as well, but I would definitely see this hypertrophy, left ventricular hypertrophy. Okay. All righty. Ooh, look at this one. Now what have we got? V1 and V2. I mean, I can't even measure where those end. I think it's coming down to here. Is this V2 going all the way down to here? I'd say he has hypertrophy. I don't know about you guys, but I would definitely say that is more than 35 millimeters. I think it may go somewhere down here, 5, 10, 15, 20, 25, 30, 35, 40, 45. And then I come over here to V5 and V6, and this is going all the way up to here. What'd I say? I don't know, 45, then 50, 55, 60, 65, 70, 75. So very large left ventricular hypertrophy. And we can see that strain pattern. This person does not have a bundle branch block. So the other one did, but this one does not, because we can see our QRS complex is not wide. Definitely have that strain though, that ST segment and that T wave having some issues there. P normal sinus. This is a little slow, looks to me. 3, 175, 60, 50. Yeah, this is really slow. This is below 50, looks to me. So some kind of bradycardia, sinus bradycardia. I think I see clear P waves in there. So with this left ventricular hypertrophy, axis. What have we got here? 1 and 3 are both positive. So do we have an axis deviation? No, no axis deviation, just the hypertrophy. So the treatment depends upon the underlying cause. Again, very likely heart failure in what we need to treat. And so ACE inhibitors, beta blockers, calcium, not calcium channel blockers for the most part, but diuretics, in surgery if we can repair that valve. Calcium channel blockers are not my favorite drug. You've probably heard me say that before. While they are good for some kind of atrial rhythms, in somebody with heart failure, they further suppress contractility and should not be. Now, right ventricular hypertrophy is its own little beast. I mean, you might have heard this as cor pulmonale, pulmonary hypertension. So not having enough, you have to maintain the right fluid balance with people with right ventricular hypertrophy. They need to have enough fluid to stretch out that ventricle and actually get it to pump. But too much and it won't move much at all as well. So very critical with right ventricular hypertrophy to have the right balance. Usually you do not develop signs and symptoms until it's pretty late with right-sided heart failure. It's typically because of something with the lungs, as we've talked about. Depends upon the etiology as whether the treatment and prognosis is. And as it's saying here, you typically don't see symptoms like the edema that can occur from backing up to the body until there's full issues here with that right ventricle. So detection is a little bit difficult. We have to be a detective to find right ventricular hypertrophy. Typically, we look for somebody that we suspected in somebody who's got COPD, long-standing pulmonary issues, or pulmonary valve. One thing that we can look for is our right atrial abnormality, so that prominent peak P wave in our pulmonary leads, which are 2, 3, and AVF. Almost always true right atrial enlargement is accompanied by right ventricular enlargement. That's correct. The other thing to look for is a very tall R wave in V1 and a deep S wave in leads V5, V6, or 1 in AVL. And they could also have an incomplete or even a complete right bundle branch block. So biggest thing that I look for is this tall R wave in lead V1. That's a pretty big sign. And so here we can see, let's start by looking for the atrial abnormality. Do we have that? That's a pretty big P. It's not huge. I'm not saying a huge P wave here or anywhere else, but I can see this really tall R wave in V1. Remember, V1 traditionally is negative. Okay, let's see. Let's step back and look at this whole EKG, because we really do need to start and follow our normal progression as we start looking at 12-lead EKGs. So let's start off by trying to figure out, is it regular and what's the rate? Looks pretty regular, 1P for every QRS. The rate appears to be 300, 150, 100, just a hair below, so in the 90s. Rate appears to be in the 90s. The PR interval appears to be about right at 0.20, so not a first degree, but just on the border of a first degree AV block. So it's sinus in the 90s. Let's see, is the QRS wide? 1, 2, not really. Let's see, at the widest one, let's check them all and see if any of these are wide. 1, 2, and 3. It'd have to be greater than 3 little boxes. 1, 2. I think I'm just getting about 0.10. So I don't think there's a bundle branch block. Let's look to see if there is an axis deviation. So in lead 1 is negative. That means we're on the left coast. So we're on the west side of that line. So in 3 is positive, which it's supposed to be. So that means it's in the southern portion. So that puts it at a right axis deviation. So this person has a right axis deviation, which goes along with right ventricular hypertrophy. And so I think there's probably some kind of pulmonary issue with this person, is what I would suspect. All right, so down here at the bottom it says dominant R wave. Yep. Dominant S wave in V6. Oh yes, look at that big old S wave. Remember that when you get around to V4, V5, V6, those should be predominantly upright. So that's an indication right there. There's something going on. And we have depression and T wave inversion. It leads V1 through V4. Yep. Okay. All right, let's look at this EKG. Oh, we don't have a rhythm strip to look at down here, so we just got to look at each one of these leads. And I see right off the bat, this is a regular rhythm, but it is slow. What is our rate here? 300, 150, 175. It's not that slow, about 75, I guess. It looked to be 300, 150, 170. Yeah, about 75, maybe even 80. I think it looked slow initially because I think it's enlarged. So it looks to me like those boxes are kind of stretched out. When I put it in relationship with those boxes, my PR interval looks to be normal. So not a first degree. There's 1 P for every QRS. The QRS itself looks to be about 0.08, maybe 0.10. So that's not large. Do we have an axis deviation? Looking at 1 in lead 3. Again, 1 primarily being left coast. So I'm thinking it is a right axis deviation. It's a west coast. It's on the west of that line. 3 is positive, which puts it at the bottom. So it is a right axis deviation. And in V1, I'm missing V5, V4, V5, V6, aren't I? Oh, how can we do that? This EKG is getting more difficult to interpret because, okay, so I'm not really able to see V4, V5, and V6 to know for sure, but having that big upright R wave in V1 is suspicious of right ventricular hypertrophy. And oh, we did have P pulmonale, right? Prominent peak P waves in 2 AVF and some of the V leads. Okay, so I think we got all of that on that one.